Welcome to Find Your Shape, a podcast by Lewisburg Plastic Surgery featuring Dr. Alexander Moya, the expert in body contouring after weight loss and inventor of the Corset Body Lift. Hi, my name is Brittany, and I will be your host. In each episode of this show, Dr. Moya and I will discuss the complex world of body contouring after weight loss. Our goal, as with everything we do here at Lewisburg Plastic Surgery, is to provide you with the educational resources you need to make the best decision for your personal situation. You've lost the weight, now let's find your shape. Hey there, Dr. Moya. How are you today?
Hey there, Brittany. I am good. How are you?
Good. Long day today. So I want to chit-chat about a concern that a lot of patients have coming into surgery, and that is blood clots. What's the risk? What do you do for prevention? What can they do at home after surgery? Tell me all the things.
That's another great question. All your questions are always great, Brittany.
Well, thank you.
And you're right. That's something that we spend time addressing with patients actually in every consultation. It's one of the risks of surgery, especially body contouring, and that we spend a lot of time making sure that we dot our I's and cross our T's for every single one of our patients when it comes to a potential blood clot which is obviously can all potentially lead to a clot that can go into the lungs. Mm-hmm. And that's something that we want to prevent. So the way we look at that for every patient, there is a actual risk stratification model that we use. Mm-hmm. And it takes a lot of factors into consideration: age, type of procedure you're having, medical issues, certain medications you take, such as contraceptives. Mm-hmm. And when we use that stratification and we add up, each one of those may be assigned a value, number. And if that number exceeds a certain threshold, let's say like 4 points, mm-hmm. then it's something we should consider when it comes to providing a blood thinner. Okay. Is one of the things big thing that patients always ask. Mm-hmm. But there's a lot of things that we can do for patients that doesn't require medication. What I mean by that is we use TED stockings, they're compressive stockings in the operating room. Okay. That's for all patients anyway, mm-hmm. who undergo body contouring. We use compression socks, pneumatic compression socks, mm-hmm. meaning they are pumps. Okay. We put on patients' legs. And what do those two things do? Well, one is it squeezes the tissues, so it helps squeeze the blood vessels so that blood isn't pooling. Okay. Especially when they get just anesthesia. Laying there. Correct. Mm-hmm. And it's not an issue with patients being awake. Most of our surgeries, when we do body contouring, they're asleep. Right. Patients don't want to be awake for that. So when they're asleep, it changes what happens to the blood vessels, and they can dilate, and then the blood can pool, especially in the legs mm-hmm. and the pelvis. And so by having these socks on, it compresses the tissue, compresses the vein, so it keeps that from happening. So it's one of the things that, as a preventive measure. Then you can go into these pneumatic compression socks, which we usually put on top of the socks, so mm-hmm. it's like a double thing anyway. And they actually pump. So they actually pump the leg as if you were walking. Okay. So as you pump the leg, it kind of pushes and propagates the blood back mm-hmm. out of the blood vessel, so it keeps it kind of flowing. Mm-hmm. But at the same time, that also releases a blood thinner that's found in the vessels, believe it or not, when this happens, mm-hmm. and it tends to thin out the blood. Okay. So those are two things that we do for all patients. Mm-hmm. So those are proven to make a difference for patients who have just normal risk. Okay. Doesn't matter what your value is on that assessment. That's the socks and the compression. And pneumatic compression devices. Okay. Correct. Now, obviously, we treat a lot of patients, and some of them have more medical issues. Some of them may even had a history of a blood clot before. Right. Does that mean that we can't help them? It creates a red flag for me. I'm like, oh, let's investigate this mm-hmm. because the biggest risk to a blood clot is having had one before. Right. Biggest risk. Then we have to figure out what circumstance that occur in. Did you have a broken leg mm-hmm. and did that lead to a blood clot? Did you all of a sudden one day wake up and your leg was swollen and all of a sudden you had a blood clot? So those are two way different scenarios there. Each one requires its investigation, because what we want to make sure is that the patient doesn't have a congenital problem with their blood, and that's the reason they're having a blood clot, meaning some kind of a genetic issue where they're not making a normal blood thinner in their own body, and they tend to clot.
Right.
So those are things that we would investigate. So obviously that's going to be something that we would need to do something more than just those compression type devices or compression socks. Maybe we start looking into a blood thinner. But those are kind of things that we look at and we take in consideration when it comes to what do we do with patients if we want to help them from the perspective of undergoing general anesthesia body contouring procedure. So if that were the case, then if it's something that I can kind of figure out on my own with the patient and say, okay, well, that happened. I don't think you're at risk for that happening again. Yes, you are at higher risk than somebody who didn't have it done. Let's start a blood thinner. And that would be a blood thinner that I could recommend myself. And when it comes down to the blood thinner itself, it's not just, do we just give it one day, which is the most common. For most patients, we would give it the day of surgery if they fall under a risk stratification where they don't require additional doses of the blood thinner. And that's pretty typical. So if somebody's undergoing a tummy tuck, for instance, and let's say they're greater than the age of 40, they have a BMI greater than 25, that's going to put them at a level where they require one dose of a blood thinner on top of the compression socks. But again, these are all the factors. I'm just giving you a few different examples. The more complicated patients then who have a genetic issue, and I'm not quite sure whether they truly still maintain that risk, I'll have them get evaluated by a hematologist.
Okay.
So we just don't say, well, you'll be fine.
Right.
Let's
And just take a guess at what they need.
We never do that. So we're very, very careful with all our patients, obviously, for their safety. And we're going to do whatever it takes to make sure that they're safe. And if for some reason it doesn't make sense, then we can't do the surgery.
Right.
I mean, that happens on occasion where I tell the patient it's not worth your risk of your life. Because one of the biggest issues with a blood clot, it's not just get a blood clot and your leg blows up and it's uncomfortable, you got pain. The biggest thing is, can that blood clot lead to a pulmonary embolism? Meaning, can that blood clot break off, go into your lungs, and cause you to have an issue, meaning die?
Right.
And that's the biggest thing when it comes to having a blood clot. The biggest fear, at least, is to make sure that that's not going to happen for any one of our patients.
Right. So that's all well and good as far as like the day of the procedure and maybe the next day, if they need additional injections of the Lovenox. But a lot of patients, if it's just the one day of surgery, maybe they fall under the category that they need the one dose of the Lovenox. What about when they get home that night, the next day? They are very concerned about the amount of walking they should be doing and how much they need to be on their feet and all that kind of stuff. What do you recommend?
So one of the biggest prevention measures for a blood clot is walking. But what does that mean? It just means that you're walking to the bathroom.
And that's enough.
You don't need to get up and be walking around 3 times a day and then get swollen
for 20 minutes.
Did a tummy tuck, or you get really swollen if we did a corset. We just don't want you laying in the bed 24 hours and getting somebody to give you food. Give me a bedpan.
Right.
I mean, so usually I tell patients, once you walk, that mechanical effect prevents you from having a blood clot.
Right.
Everything is being pushed. All the blood is circulating through your body, especially in your lower legs. There's a pump. There's a pump mechanism in the foot, and that compression is enough to prevent a blood clot.
Okay.
So all they need to do is just be getting up to go to the bathroom, getting up to get a drink of water, plenty for preventing a blood clot.
Okay.
Absolutely.
Wonderful.
So that's one of the things that and again, that also dictates how long do you give a blood thinner. And I'm not going to get into that because it gets complicated. All patients have to know it's an individual thing. Do we just do 1 day? Do we do 5 days? Do we do 10 days?
Right.
Do we do 2 weeks if patients have had a history? But that's something that we'll work out individually. So patients don't have to worry about that. What they do need to know is that we are going to worry about it for them.
Right.
We're going to make sure that we do the right protocol for them.
Right.
And it's part of our workup.
Right. As well as recommendations for traveling home if they've, have a bit of a distance to drive or fly.
Correct. So for us, we would err on being conservative. I would rather give them the blood thinner if they're going to be all of a sudden now not moving around on a plane for 3 hours or 4 hours. So I tend to give a blood thinner for the travel home. on the flip side, some patients will say, well, why doesn't everybody get blood thinners? Well, because there's a risk of bleeding.
Mm-hmm.
So, and that comes down to our technology. I know we've talked about our technology in the past in a previous podcast. Ultrasonic energy, the tools that I use, seals blood vessels differently than electricity, meaning the electrical tools that we'll use, because what happens is with that tool, that creates a clot at the end of the blood vessel that's been cut. That clot can all of a sudden pop off if you're thinning out the blood, and then you have bleeding.
Right.
With the ultrasonic tools, it actually seals the blood vessels like glue seal.
Okay.
That can't pop off. So I've, in my own hands, this is again in my own hands of my own experience, because this is the tools that I use. If you're paying attention, you can clearly see the differences between two different modalities of energy sources. And I've seen for myself that when we use that tool, I've been able to give blood thinner before surgery. A lot of surgeons might do it after, and I've even been able to give blood clot the day before surgery. Even so, now they're getting 2 doses before they even come into surgery.
Right, without any issues.
Correct, without leading to what we call a hematoma, which is a collection of blood that builds up because the patient is bleeding from a vessel that it's popped open post-surgery. We just don't see that. And I truly believe that's due to part of the technology, which is great because that means that we can keep patients safer with these big procedures that I do.
Right.
So.
Okay. Awesome. That's a lot of great information. I think a lot of patients are very nervous about that, so hopefully that'll ease their mind.
Great. Thank you so much.
Yeah, thanks. That's a wrap on this episode of the podcast, brought to you by Lewisburg Plastic Surgery and Dr. Moya. Please be sure to subscribe to our show so that you never miss an episode. And for more information on Lewisburg Plastic Surgery or the course of body lift by Dr. Moya, please visit us online at lewisburgplastic.com. We'll see you next time.